Good afternoon. I would like to thank Dr. Krishnan and Dr. Scheinert for inviting me to speak at this symposium. I'll be talking about the role of covered stents in Femoro-Popliteal disease. I have no disclosures related to this topic. Actually, the only stent that is covered stent that's approved by FDA for the use in the SFA in US is Gore VIABAHN stent. It's a PTFE tube that is supported by a Nitinol frame and has a surface that's covered with heparin to prevent stent thrombosis. It also has a contoured proximal edge to prevent infolding of the stent and minimize the chance of the proximal edge restenosis. It is a what happened here? Okay. It is a very low incidence of. It has very low incidence of reported fractures. It's capable of longitudinal compression with little residual force and has superb flexibility. Let's look at some clinical studies done with this particular device. There is a Gore Viper clinical study. That was a prospective multicenter study. They studied 119 limbs. The average lesion length was 19 centimeters, 190 millimeters, which is quite an impressive length of the lesion for SFA trials. And 56% of those lesions were CTOs. And you see that primary patency rate at 12 months with this stent was 73%. What we learned from this study that device sizing was extremely important, and patency improved when device was not oversized for more than 20% proximally. So if you get the size of the device correctly, then the patency rate was 88%. And if the stents were oversized, then the patency rate would go down. And in this particular study, at 12 months, it would drop to 70%. It's interesting that Japanese study where they used, again, VIABAHN stent for SFA disease, but where they used either intravascular ultrasound or quantitative angiography to evaluate the landing zones to make sure that they get sized correctly. They observed also the same primary patency rate of 88% at 12 months. So another interesting observation was that the patency of the stent was independent of device diameter, as well as it was independent of lesion length, which is very interesting observation and not typical for other devices. They did a sub-study analysis when they looked at the calcified long SFA lesions. And as you can see, even in the very long lesions of 19 centimeters, the patency rate at 12 months was 84%, pretty good. The VIASTAR trial studied VIABAHN stent versus Nitinol bare metal stents in patients with SFA disease. And as a Nitinol stents, there are 3 stents were used, which are Live stent by Bard, Protege by Covidien, and Smart by Cordis. There were about 70 patients in each group. And if you look at the lesion characteristic, again, it's impressive in terms of the complexity of the disease in those 2 groups. With the CTO in VIABAHN group, almost 80% of the patients had the CTOs, and in bare metal, about 70% of the patients. Mean lesion length in VIABAHN group was 190 millimeters, and in BMS group, 173. Long lesions, a lot of CTOs. These are the results at 12 months, and again, primary patency rate in VIABAHN group was 78% versus 54% in patients with bare metal stents. And in long lesions, again, VIABAHN lesions longer than 20 centimeters, the patency rate at 12 months with VIABAHN was way better at 73% versus 33% in patients in BMS group. If you look at safety endpoints, there were no difference, and both approaches were quite safe. So what we learned from those studies is the fact that VIABAHN stent actually, one of the hypotheses why it kind of performed better, because the VIABAHN actually covers the whole disease segment and possibly prevents the progression of the disease in this particular segment that's covered, as opposed to bare metal stents that are open cell, have an open cell scaffold, and which allows for the disease progression and neointimal proliferation growing inside the stent and causing restenosis. So in terms of restenosis patterns, it's very different for VIABAHN versus bare metal nitinol stent. BMS, as you know, has typically diffuse in-stent restenosis, and with VIABAHN, we usually observe the restenosis at the edges. That's why it's very important to follow up patients with VIABAHN very closely, so you would catch this restenosis at early phase and treat it as needed, rather than wait for the restenosis to progress and the whole stent to close. In terms of the lesion length, again, VIABAHN patency was not dependent on the lesion length, and in BMS group, patency decreased with lesion length. Fractures very, very rare with VIABAHN, and in BMS it varies. It depends on the type of the stent and stent design. So this slide again emphasizes the fact that that there is no significant drop in patency as lesion length increases in patients who received VIABAHN stent, and it drops significantly in patients who received bare metal stents. So what about randomized multicenter prospective clinical trials for treatment of in-stent restenosis? We know that there are 3 trials: Rewind clinical trial that compared VIABAHN stent versus balloon angioplasty, Excite ISR trial comparing laser atherectomy plus PTA versus balloon angioplasty alone, and a FAIR trial comparing Impact DCB versus plain balloon angioplasty alone. What Rewind trial showed us that there was about 75% patency rate after treatment with VIABAHN, comparing with 28% patency rate in patients who were treated with balloon angioplasty. And again, as Bill pointed out on the previous talk, this is not a fair slide and fair comparison. We are not truly comparing apples to apples here. But if you look at the lesion length, again, in Impact, in the drug-coated balloon trial, the lesion length was 8 centimeters with 70% patency rate at 12 months. And in the Rewind trial, the lesion length was much longer, 17 centimeters, so with 75% patency rate. And in Excite ISR, 19.6 centimeters with quite low patency rate of 40% with laser. And if we look at the recent randomized, again, or prospective multicenter trials for drug-coated balloon and VIABAHN endoprosthesis, and looking at lesion complexity, you see that patients who were studied with VIABAHN stent had much more complex disease. Same is true for trials with drug-eluting stents or trials with bare metal stents compared to VIABAHN stents. So what we learned from VIABAHN trials is that VIABAHNs provide complete coverage of the disease segment for complex cases. It has proven patency for long and complex SFA lesions, and has better results than bare metal stents in complex SFA lesions. Has very good patency independent of lesion length, and has proven efficacy for ISR treatment. Thank you for your attention.